Good evening, delegates and participants. Okay. Good evening, delegates and participants. Thank you for joining Shield Connect. And today we are back with our webinars. And today we have a speaker, Dr. Lakshmi Chirumamilla. Ma'am is going to take a topic, current trend in endometriosis. So before I introduce ma'am, let me give a little idea about our page, shieldconnect.in. So you can connect on this page and you can find different sections are available like blogs, webinars, and special day pages. So if you click on blogs, you will find all the blogs that are written by the speakers and doctors who are connected with our Shield Connect. And then if you click on webinars, you can find all the details regarding the upcoming webinars. So you can just log in through this webinar page. Just you have to email ID and you will log in. And we also have our leader page where you can find a detailed profile of speakers who are connected with Shield Connect. So this is regarding Shield Connect page. And now let me introduce our speaker for the day, Dr. Lakshmi Chirumamilla. Ma'am has done MBBS, MD in obstetric and gynecology, MRCOG from UK, a fellow of Royal College of Obstetricians and Gynecologists, FRCOG from London. Ma'am is infertility specialist, reproductive endocrinologist in infertility department, and ma'am is clinical director and senior consultant in reproductive medicine in Nova IVF fertility clinics. So I welcome you, ma'am, on our platform for today's webinar. And I hand over the session to you, ma'am. Thank you so much for giving your precious time.
Thank you. Thank you, Nishant. I will share my slide.
Yes, ma'am.
Sorry, I'm confused. Just
Yes, ma'am. Yes, ma'am.
1 second.
Yes, ma'am.
Hello, good evening, everyone. At the outset, I would like to thank you all for taking time and being part of this webinar and this knowledge sharing session. I was asked by Shield to talk about endometriosis and the recent trends. And we all know that the incidence of endometriosis is increasing day by day. And the WHO statistics, which was published by WHO in March 2021, says that around 10% of the reproductive age women and girls globally suffer from this problem. And there is difficulty in diagnosis, and a lot of the patients suffer the pain without even being diagnosed, either because of lack of awareness or because of the difficulty in diagnosis. So today, my talk will include how to diagnose endometriosis and staging of various staging systems that are available for endometriosis, the impact of endometriosis on fertility, and the treatment options available in terms of fertility mostly, and a little bit on pain. So what are the various diagnostic modalities that we look at to identify or diagnose the problem? If we are able to diagnose a problem early, we can curtail the disease process and at the same time give comfort to the patient. So what are the various things that we need to look at? Obviously, history is a cornerstone, and then pelvic examination also aids us in diagnosing the problem. And nowadays, the recent trend is that we don't have to go for laparoscopy, which was considered to be the gold standard in diagnosis, but at a TVS done by an experienced radiologist or a gynecologist with interest can identify endometriosis as good as an MRI. And then the mapping systems, and the recent trend is TVS with an enema will give us a better identification features than just a TVS on its own. And the role of laparoscopy will be discussed in the next few slides. So if you look at the scan picture, you can see this yellow line is the cervix, and this is the uterus, which is acutely retroflexed. And you can see it is acutely retroflexed, and it could be because of some adhesion inside. So when you see these type of pictures of the uterus, definitely we think of some cause of adhesions within the pelvis. So we should suspect endometriosis or any PID or any previous surgery. So that will give us a clue towards the differential diagnosis. And then you can see the ovary just attached to the uterus as well. And that is the ovary just adherent to the uterus. And at the same time, you can look at the slide for the sliding sign also. What does the sliding sign means? So when you do the ultrasound, and if you put one hand on the uterus, just like how we do bimanual examination, and usually the ovaries slide easily onto the uterus, even if they are just above the uterus. And the uterus also moves as you move the probe. But if there are adhesions, then the sliding sign is missed. So that is also one of the pointing features towards the adhesions within the pelvis. And you can see two ovaries in one slide of a pelvic scan. These are called kissing ovaries, and this also gives us a clue that there could be some adhesions in the pelvis. It doesn't point towards endometriosis, but it gives an identifying one of the differential diagnosis. Then what is the diagnostic feature of an endometrioma? It gives us a ground glass appearance with 1 to 4 compartments, and we don't see any papillary projections with blood supply within the cyst. So this is a typical appearance of endometriotic cyst of the ovaries on the TVS scan. Again, this is the ground glass appearance, the hazy appearance, some hyperechogenic lines within the cyst. So this is the International Deep Endometriosis Analysis Group called IDEA, which came up with some identifying or mapping features which we need to look at when we are doing an ultrasound. First, they suggest to assess the uterus and the adnexia, looking for adenomyosis and endometriosis. Like what I have mentioned previously, we could also look like soft markers like tenderness and mobility. So when we put the probe in, and if we are moving the probe, if the patient winces in pain, that is the way we identify tenderness, and the mobility in terms of sliding sign. Then assessment of the pouch of Douglas plus sliding sign, and assessment of DIE, deep infiltrating endometriotic nodules. And the Cochrane meta-analysis found that the transvaginal ultrasound approaches the sensitivity and specificity needed to replace surgery for endometrioma detection. This is what I was telling. Previously, when we were doing post-graduation or undergrad, we were told that the gold standard test for identifying endometriosis is laparoscopy. But slowly, this is being replaced by transvaginal ultrasound, and especially if we go systematically, and if we have an thought to identify these, and if we keep it at the back of our mind when we are doing every ultrasound scan, it will be easy to identify endometriosis. Even recent studies say even we can identify pelvic endometriosis as well when we look at these parameters. And the sensitivity increases if we use a bowel preparation before we do ultrasound. So where does laparoscopy stand now? It was a gold standard at one point of time, but selection of cases is very important. We shouldn't be subjecting everyone for laparoscopy. If there is any other indication for laparoscopy and there is no other infertility factor, then only surgery is necessary. As such, surgery is not necessary before all ART procedures in patients with endometriosis. And then what are the pros and cons of surgery? We can identify the extent of the disease. And if it is minimal disease, we can treat the patient there and then. And there are studies which say that surgical treatment of endometriosis, especially of stage grade 1 and 2, will improve the pregnancy rates, that is minimal and mild, by revised American Fertility Society classification. What are the disadvantages? In certain group of patients, definitely doing surgery will not improve the success rates, especially severe and extensive diseases. And if you happen to remove the endometrioma, then there is every chance that we can reduce the ovarian reserve. So there are studies which say that removing the endometrioma is more detrimental than doing surgery, than doing ART with endometrioma in place. So as I have mentioned previously, if you look at the history and symptoms, persistent or worsening cyclic or constant pelvic pain, dyspareunia, dysmenorrhea, and cyclic dyschezia or cyclic dysuria, and cyclical catamenial symptoms located in other body systems like lung and skin, and previous history of infertility, dysmenorrhea in adolescents, current chronic pelvic pain, previous laparoscopy with diagnosis of endometriosis, dysmenorrhea which is non-responsive to NSAIDs, and a positive family history with endometriosis direct us towards endometriosis. On physical examination, we can see nodules in the cul-de-sac. We can feel the nodules in the cul-de-sac, a retroverted uterus, a mass within the ovaries. Sometimes, very rarely, we might see an endometrioma within the vaginal wall on a speculum examination or on the skin. So endometrioma and ultrasound definitely points towards endometriosis. Presence of soft markers like tenderness and sliding signs, and nodules and masses in the adnexia. So coming to the classification systems, there are 2-3 classification systems that have come up. The first one is American Fertility Society classification system, and it was done in 1969 and then revised in 1985. And here we see the various parameters looking at the lesions and the adhesions. So each of them were given certain points, and we look both at the, if you are looking at the lesions at laparoscopy, we look at the extent or the damage of the lesion, or also in the depth of the lesions. And when we are looking at the adhesions, we look at the adhesions of the ovaries and the tubes and the extent of adhesions, and whether they are flimsy adhesions or dense adhesions. And if they have given 40 points if the posterior cul-de-sac is fully obliterated. And depending upon the extent of the points that have been given, we can identify the severity and divide them into minimal, mild, moderate, and severe. And there is another revised classification which came up in 1980s. Not the revised one, I'm sorry, but this is the EFI scoring system to look at the fertility index of that particular patient to see how she will fare in achieving pregnancy after the laparoscopic surgery. So here they are looking at various epidemiological or features like age, duration of infertility, previous pregnancies, And they also included the American scoring system also. And they also will look at the functional capacity of the ovaries, the functional capacity of the tubes, and the fimbria that they have noted on during the laparoscopy. So again, they will give points from 0 to 4 depending upon their functional capacity. And that they plotted against the pregnancy chances. And if the score is less, the pregnancy chances are less. And this AAGL classification is dependent upon the to look at the deep infiltrative endometriosis. Again, they look at the depth and also the extent of the disease, and they take into consideration 3 compartments in relation to the uterus. And this is more into for laparoscopic assessment of the deep infiltrative disease. So coming to the treatment, the main reasons why patient approach a doctor is either because of pain, most commonly because of pain, but sometimes it could be because of infertility. So if it is pain, it could be various forms of pain. And most of the times, we resort to medical therapy to resolve this pain. And most of the therapies are directed in inhibition of ovulation. So eventually it will inhibit the hormone production. And so this can't be used in women who want to conceive. So that is a big no. Especially in women who want to conceive, we shouldn't be using this because all of these treatments will reduce the, will stop ovulation. So if you look at the various molecules that have been used, NSAIDs, hormonal therapies like oral contraceptive pills, progestogens, anti-progestogens, and recently the GNRH antagonists are also being used very efficiently in US and other advanced countries, and aromatase inhibitors. So there are so many various agents that can be tried upon. So previously, when danazole was available, we were using danazole. And now in between, a lot of GNRH agonists have been used, which mimics medical oophorectomy. And we can, as we all know, that we can use only for 6 months. And if we are using for more than 6 months, we should do add-back therapy. And we can continue that for another 6 months. And the recent case on the block is the GNRH antagonists. They are available in under three names. They are algolics, linzagolics, and relugolics. Whoever has side effects with progestins, they can be put on these agents. And the main advantage is they can be taken orally. GNRH agonists should be taken as an injection, but antagonists can be taken orally. They were available as an oral preparation. There are 2 different doses, and the response is dose dependent, and it starts acting immediately. The GNRH agonist, because of its initial flare-up effect, the pain increases. But the advantage of this is it starts its action immediately. So that is also one of the advantages. Then you can ask me about the side effects. They also have similar side effects because of lack of estrogen. So hot flushes and prolonged use can affect the bone mineral density. So even these antagonists should come with, we have to use add-back therapies. So coming to the fertility, the normal fecundity is 15 to 20% in normal couples, but in women who have endometriosis, the fecundity rate goes down. It goes down to almost to 2 to 10%. What are the various causes of decreased fecundity? It could be because of altered anatomy, abnormal uterotubal transport, altered peritoneal function, because of the various cytokines that have been released. And if you look into the depth of it could also be because of the scar tissue, which can lead to luteinized unruptured follicle. It can lead to luteal phase deficiency. long follicular phase, and premature LH surges. But if you look at in depth, what they have noticed is oocyte quality has been affected because of the toxic cytokines that are there in the pelvis of women with endometriosis. At one point of time, it was thought that if we do ART for women with endometriosis, the success rates are less when compared to women with other causes of infertility like tubal factor or unexplained infertility. But recent studies have shown that when we take away the eggs from the uterus, from the ovaries, without being exposed to this toxic environment in the pelvis, they are supposed to give us good quality eggs and embryos. And now most of the studies have shown that there is no difference in the pregnancy rates in women with endometriosis when compared to other tubal factor or unexplained infertility. But there is alteration in the uterus, and along with the oocyte quality being affected with these cytokines, there is also there are also notable changes that happen in women with endometriosis in terms of utopic endometrium also. So there is activation of oncogenic pathways, which leads to increased production of estrogens, cytokines, prostaglandins, and metalloproteinases within the pelvis. And these affect natural activation of progesterone receptor gene. And they also documented nerve tissue within the endometrium. All these lead to inflammation and altered endometrial receptivity. So not only the oocytes get affected, the quality decreases, but also the endometrial receptivity is affected, which would lead to reduced fecundity in women with endometriosis. So that is why natural conception rates are less. So what do we do in these women? Women with minimal to mild endometriosis, so many trials have been done. So surgery is one of the modalities we can try in minimal to mild endometriosis. And initially they said that the number needed to treat was 12. And in unexplained infertility, it is 40. So whenever we do laparoscopic surgery and we happen to see endometriosis, the advice is to burn the endometriotic spots so that we can increase the chances of pregnancy in those women. And the recent study published by Versellini, he has studied for a period of 12 to 18 months in women with minimal to mild endometriosis, and the natural pregnancy rates he got were around 50%. So we can try especially this surgery in women with mild to moderate, minimal to mild endometriosis, provided the ovarian reserve is good, the tubes are patent, and husband's semen analysis is normal. If there is any change in any of this, then obviously this is not the right modality of treatment. In severe endometriosis, if you look at surgery, the cumulative pregnancy rates of after 2 years after LAP are around 45 versus 63%. Whether you do laparoscopy or laparotomy, there is no significant difference. But a laparoscopic cystectomy is better than cyst drainage and coagulation, because drainage will lead to immediate pulling up of the fluid again, and recurrences are very common. And repeat surgery does not increase fecundity, and it is a big no in the present scenario where we are avoiding one surgery on itself. And where do you go for expectant therapy? When there is limited disease and minimum symptoms, and in young women and who have been trying for a short duration of time, then expectant therapy also can be offered for a very short duration of time, not for like years together, but maybe a few months, 3 to 6 months. So if you look at this table, you can see they have studied women with stage 1 or 2 endometriosis and compared with unexplained infertility. There are various authors here, and they have tried various treatments. So in endometriosis, no treatment or intracervical insemination. You can see in unexplained, the percentage pregnancy rate is 2, and others have documented around 3 to 4.5. IUI, there were no studies done comparing unexplained infertility, but clomiphene and IUI, the chances are better. See, when you compare no treatment to clomiphene and IUI, almost 3 times increase in the pregnancy rates. In the same way, gonadotropins on its own or gonadotropin IUI, again, there is increase in the pregnancy rates. And only one study looked at IVF, but this is an old study published in 2012 by the Practice Committee of ASRM, American Society of Reproductive Medicine. So any treatment, any form of treatment, you can see there is increase in the pregnancy rates in women with endometriosis. And where does superovulation and IUI stand? So it improves success rates in women with grade 1 and 2 endometriosis. The evidence is grade 2 evidence. And the numbers needed to treat are 14. So if you treat 14 women with IUI and superovulation, one will conceive. And the percentage success is the same, whether it is minimal, mild, or unexplained infertility. Will the success rate improve if you give do a surgery for that woman before IUI? There is no evidence which looked at like this. So just a evidence, the case review. A 30-year-old, she has been trying for 4.5 years. Laparoscopic ovarian cystectomy was done. Husband was azoospermic, abstract to azoospermia. We could retrieve sperm by surgical sperm retrieval. And the wife had endometriotic cyst of 4 into 4.5. So this is a recurrence again within a short duration, but luckily she had good antral follicles of 9 and 8. At that time we were using a down regulation only. This is quite a long time back. 1 month we did down regulation followed by 2 cycles of OC pills and started stimulation with an antagonist cycle. Retrieved 12 mature oocytes, 11 fertilized with PISA sperm, 6 embryos were frozen. And in the first cycle, it was negative, but second cycle, she conceived and had a baby. She came to us again recently also, and for a second baby, and she had a second delivery also. So where does ART stand in women with endometriosis? As I have mentioned previously, we were thinking a lot of studies have shown that endometriosis reduces success rates of ART cycles. But IVF maximizes cycle fertility because we will have a lot more eggs than natural conception, and we can get select the best embryo and transfer. So cycle fertility will be better. But recent updates says that with the segmental approach, the success rates of women with endometriosis post IVF are very good. But the thing is better to go for a GNRH antagonist protocol, which reduces OHSS risks with a GNRH agonist trigger. So this lady is another interesting case study. 26 years old. She has been trying for 8 years. She had an endometriotic cyst removal at the age of 16. When she came to me, her FSH was 23. At 23 FSH, the success rates are very, very less. And she had a recurrent endometriotic cyst. So we happened to remove the cyst. Her FSH came down to 8. We all know that the FSH is fluctuating. But interestingly, we could get 4 oocytes, 2 grade C embryos. We never thought that she will conceive, but she had this baby. So most of the times when women and also most of the doctors also think that if a woman has endometriosis, the chances of conception are less. But these are only a few studies, case reports. But I would say most of the women who come to us who had treatment, they have achieved pregnancies most of the times with their own oocytes, even though they had less ovarian reserve. That means ovarian reserve would be compromised. Their response to GNRH gonadotropins is less, but their embryo quality is decent enough to give us pregnancies. So let us not lose hope, thinking that the success rates are less post-ART. They have good chance of pregnancy post-ART, even if they have reduced number of eggs. So do we have to go for cystectomy? Where do we stand? There are no RCTs, but the main reason to remove a cyst should be either a pain, or they have large cyst, or difficulty in accessing the ovaries during ART cycles, or if they had rupture, or to prevent fast progression. So these are the studies. You can see surgery does not improve ART outcomes. So there is no need to do a surgery on its own, or there is no need to do a surgery to remove the endometriotic cyst, even if it is existing. Actually, surgery may actually cause more harm by impairing ovarian reserve. ART does not worsen endometriosis symptoms. This is a very common question asked by our patients, that, and they are worried that, when we give hormones, ART can, endometriosis can get worse, but most of the studies said that there is no worsening of symptoms post ART, and the ART also doesn't impact ovarian endometrioma or deep infiltrating endometriosis. Role of GNRH pretreatment. Previously, it was used extensively, but we had only 3 RCTs. But recent X-ray guidelines say that there is no strong evidence to support pre-ART GNRH downregulation. But the recent trend is to go for segmental approach. So antagonist protocol, freeze the embryos, downregulation for a couple of months, and then transfer the embryos with estrogen and progesterone supplementations. So finally, to conclude, younger women with grade 1 or 2 the treatment strategy should be either expectant management if they have been trying for short duration, superovulation with IUI or surgery, laparoscopic surgery and treatment. If they are more than 35 years or longer duration of infertility, then superovulation and IUI for 1 or 2 cycles, followed by ART or ART directly, depending upon the ovarian reserve. And in stage 3 or 4 endometriosis, superovulation and IUI, at least 1 or 2 cycles, if the ovarian reserve is good. If they don't conceive, then moving to IVF. So this is another case of a 36-year-old woman. She has been trying for 10 years. She was a resident of USA. She had laparoscopic cystectomy, but she had a recurrence of cysts. Recurrence of cysts is very common, mostly because either the cyst is not completely removed or it's only drained. And she had only 4 antral follicles. Used antagonist protocol at that time, mainly because she did not have time. 3 oocytes, 3 embryos, and she conceived. So coming to the pregnancy outcomes, preterm labor is documented, preeclampsia, antepartum bleeding or placental complications, and cesarean sections are more common in these women. With proper treatment, the prognosis is good for pain relief and enhancement of fertility in mild to moderate endometriosis. In most cases, hormonal therapy is temporarily effective in controlling symptoms and arresting growth, but is generally less effective than surgery in increasing fertility. The recurrent rate is very high. Prevention is always better. Avoid possible augmentation of menstrual reflex. Taking oral contraceptive is recommended if there is any suspicion of endometriosis, especially in girls who are coming with severe dysmenorrhea, and isolation and irrigation of the operative site to prevent dissemination. There are so many recommendations given by an X-ray, which was published in 2022. So I will just read out them. In infertile women with endometriosis, clinicians should not prescribe ovarian suppression treatment to improve fertility, already discussed. So we shouldn't use any medical treatment for these women who want to conceive, because that only reduces the chances of pregnancy, because most of the medical treatment will prevent ovulation. Women seeking pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance future pregnancy rates. Previously, it was a practice that post-operatively we used to give 3 injections of GNRH agonists, long-acting GNRH agonists, to suppress further recurrence. But the recent guidelines say that we should start treatment immediately rather than giving suppressive treatments. Those women who cannot attempt to or decide not to conceive immediately after surgery may be offered hormone therapy, as it does not negatively impact their fertility and improves the immediate outcome of surgery for pain. In infertile women with endometriosis, clinicians should not prescribe pentoxifylline and other anti-inflammatory drugs or letrozole outside ovulation induction to improve natural pregnancy rates. So just for ovulation induction purposes, we should give letrozole, but not for other reasons as mentioned. Operative laparoscopy could be offered as treatment option for endometriosis associated infertility in revised ASRM stage 1 and 2 endometriosis, as it improves the rate of ongoing pregnancy. Clinicians may consider operative laparoscopy for the treatment of endometrioma associated infertility, as it may increase the chance of natural pregnancy, although no data from compared to studies exist. We might consider, but it can be detrimental. So we should be careful while suggesting laparoscopy for an endometrioma removal. No compelling evidence exists that operative laparoscopy for TE improves fertility. Operative laparoscopy may represent a treatment option in symptomatic patients wishing to conceive. In infertile women with stage 1 and 2 endometriosis, clinicians may perform IUI with ovarian stimulation instead of expectant management or IUI alone, as it increases pregnancy rates. Although the value of IUI in infertile women with stage 3 and 4 endometriosis with tubal patency is uncertain, the use of IUI can be considered. ART can be performed for infertility associated with endometriosis, especially if tubal function is compromised, if there is male factor infertility, in cases of low EFI, and or if other treatments have failed. A specific protocol for ART in women with endometriosis cannot be recommended, but GNRH agonist and antagonist protocols can be offered based on patients and physician preferences. Women with endometriosis can be reassured regarding the safety of ART, since the recurrences are not increased compared to those women not undergoing ART. In women with endometrioma, clinicians may use antibiotic prophylaxis at the time of oocyte retrieval, but the risk of ovarian abscess is very minimal. The extended administration of GNRH agonist prior to ART treatment to improve live birth rate in infertile women with endometriosis is not recommended, as the benefit is uncertain. There is insufficient evidence to recommend prolonged administration of COCR progestin as a pre-treatment to ART to increase live birth rates. Clinicians are not recommended to routinely perform surgery prior to ART to improve live birth rates in women with stage 1 and 2 endometriosis, as the potential benefits are unclear. Clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve live birth rates, as the current evidence shows no benefit. Surgery for endometrioma prior to ART can be considered to improve endometriosis-associated pain or accessibility of follicles. The decision to offer surgical excision of deep endometriosis lesions prior to ART should be guided mainly by pain symptoms and patient preference, as its effectiveness on reproductive outcome is uncertain. So thank you so much, and we can.
Thank you so much, ma'am, for giving crisp and detailed information regarding this topic. So let me check if we have any queries in the comment section. Okay, ma'am. Give me 1 minute.
Yes.
Ma'am, I cannot find any questions, but there are very good feedbacks that the topic was very clear and crystal clear. Thanks to ma'am in our YouTube channel page and on this Shield Connect platform. So ma'am, thank you so much for giving your precious time, and we would like to have more sessions with you in upcoming future, ma'am. Thank you so much.
Thank you. Thank you so much for giving me the time and opportunity. And I thank all the participants.